Male patient, 63 years old, with history of obstructive jaundice. ERCP was done, showing a swollen papilla. Biopsy, cannulation of the common bile duct, revealed dilated common bile duct with insertion of 2 stents. Pathology of the lesion, so tubulovillous adenoma with low-grade dysplasia. The patient is for EOS. And now with the live transmission with Professor Hakan, sorry.
Hello, you can hear us? Professor Hakan, you can hear us? No, we cannot hear you. But we can see you.
Okay. You hear now?
Yes, yes, go ahead.
Okay. Ladies and gentlemen, first of all, I would like to thank to the organizers of this meeting for inviting me to Egypt. This is a fascinating country and city every time. I am here examining a patient with a papillary, presumably tumor, with my dear friend, Professor Okasha. We have been working for the last 4 years together, and I am very happy to be with him again. This patient presented with a quite characteristic picture of an obstructive jaundice, and in ERCP they found a tumor, and the biopsy revealed villous adenoma, and they put a stent to relieve the jaundice, as far as I understand. In this patient, why we are performing US, this is for the purpose of the staging of the tumor and to delineate whether this is a good candidate for endoscopic papillectomy, which is becoming quite popular, and whether this patient is actually a candidate for surgical treatment, the so-called Whipple procedure. And we start from esophagus. Actually, in EUS, there are different approaches. One is that you start from proximal part, then you go down. The other is that you intubate duodenum. You start from the deepest level, and another approach is that you start from the lesion. You examine the lesion, then you go on with routine examination. Today we are going to start with mediastinum. Now we are at 28 centimeter, and Professor Okasha is showing you the left atrium and pulmonary artery, and in between them the so-called subcarina. What is the advantage of starting examination from here is that there may be metastasis even to the subcarina in some types of peripapillary tumors, so it is better to start examination from the proximal in these cases. But what we see here is that in subcarina there is no pathological lymph node which may be considered for metastasis, and we go 2 centimeter proximal to see the aorticopulmonary window. This is aorta, this is pulmonary artery, and between aorticopulmonary window, that is another site of mediastinum, which is interest because generally the lymph node metastasis from any site will be to these sites, and there is a very small lymph node, but yes, here, but this lymph node is not pathological. And in mediastinum we may encounter sometimes large nodes which may be due to the so-called pneumoconiosis. I don't know whether it is present in Egypt, occupational disease. So even if there are some lymph nodes in this area, one should not be certain that this is a metastasis, and final aspiration may be necessary. Then we found our way into the stomach, and the first structure in stomach we bump into is liver. And this is the left lobe of the liver. There are some air image in biliary duct, and now there is no significant duct dilation. So presence of air indicates that for this patient a sphincterotomy was performed and it is effective, that there is no significant duct dilation. And when we examine the portal area here, the portal vein is open. When we see the portal vein, we do a 130-degree clockwise rotation, and we now examining the body of the pancreas, which is the body of the pancreas. Actually, even if there is a pathology in the head of the pancreas, first examination, the body of the pancreas makes sense, because in case of pancreatic head tumor, generally we see a pancreatitis-like picture in the body of the pancreas. In addition, sometimes atrophy and mostly duct dilation. Now, Professor Okasha is showing you the duct which is quite dilated. We can measure it, and I think it is something like 3 millimeters, which is more than expected in physiological condition. It is now we are measuring it. Yes, it is around 3 millimeters. So in body, it should not be more than 2 millimeters. So it indicates a minimal or mild duct dilation, and we see that this is a diffuse dilation. There is no atrophy and there is no chronic pancreatitis-like picture. So these negative findings here are standing against a pancreatic head tumor. Of course, we cannot exclude it, but in any case of papillary obstruction, we are talking about a peripapillary tumor. This peripapillary tumor may either be a real papillary carcinoma or adenoma, or it may be a part of pancreatic carcinoma and even cholangiocarcinoma. Because of this, in general, we are talking about peripapillary tumor. And the best definition of what it is will be done with EUS. Then we intubate the duodenum, and after intubating the duodenum, while going to the deep, we are doing a maneuver like this. We do a right turn. You see, I am not pushing the scope, because a perforation of the first part of the duodenum is a concern with this type of scopes. We do a right turn, and then you see, even if I do not push the scope, it is sliding slowly to the third part of the duodenum. I am slowly withdrawing, not actually pushing, withdrawing, like it is in ERCP, and now we are withdrawing to the third part of the duodenum. That is a very important maneuver. The people who are coming to my unit to learn the basics of endoscopy, this is the first maneuver I show them, and you intubate the bulb, then you do a right up, and you turn your body to the right, and you actually withdraw the scope. With sliding, you are going to find your way to the third part of the duodenum. We start examination from the fourth station, which is the third part of the duodenum, and the immediate vessel is aorta, you see. And when we see the aorta, we are pulling back with small rotation of the scope, clockwise, counterclockwise. While doing EOS, we are doing this maneuver very frequently. And while we are withdrawing or pushing, we are doing 30 degrees of clockwise and counterclockwise to see the vicinity of the place we are examining. We are now withdrawing, and the first structure will be the uncinate process of the pancreas. Now we are seeing the part of uncinate process now at the right of aorta up. Yes. Now we examine the uncinate process. In uncinate process there is no pathology, and we are withdrawing very slowly. And now we are going to examine the head of the pancreas. We are going back slowly. Yes, now the head of the pancreas is in full view, and at the extreme right you will see the appearance of papilla. This is the macellaris propria, you would say, yes, the macellaris propria, and adjacent to macellaris propria we are examining papillary region. very slowly, very slowly. Yes, now we see the stent which has been put previously. Actually, that is a controversial issue for these patients, whether to perform EUS first or to perform ERCP first. And the studies have shown that there is no difference. Even if you do ERCP and put stent, it will not decrease your diagnostic capability. And even sometimes it may be useful that you would find easily. And now Professor Okasha will show you the muscularis propria. Here you see it is continuous, yes, and the stent is actually protruding from common bile duct into the duodenum, the second part of the duodenum. We are withdrawing slowly, and we are trying to examine the rest of the pancreatic head. And now we see a dilation of the pancreatic duct better here. Pancreatic duct is significantly dilated in the head of the pancreas, and now we see in full view the mass. The mass is surrounding the stent, you see, and it is actually causing pancreatic duct dilation. We can measure the mass here. Yes, please. And then please measure the mass. Yes. To the,
I think
yes, it is around 20 millimeter, 20 to 25 millimeter. It is quite a large mass actually, and actually it is invading muscularis propria. For papillary tumors, staging is like this. If it does not invade muscularis propria, it is stage 1. If it invades muscularis propria, it is stage 2. If it invades common bile duct or pancreatic duct or both less than 2 centimeter, it is stage 3. And if it invades common bile duct or pancreatic duct or both more than 2 centimeter, it is stage 4. For stage 1 papillary tumor, papillectomy may be performed even if it invades some part of submucosa. But for this particular patient, what we see is that muscularis propria is invading. We cannot tell apart muscularis propria here. Okay.
Here muscularis.
Now, for the sake of the time, we should be a bit quick. In 2 minutes, I am going to finish this case. What we see here is that this tumor is invading pancreatic duct, and it is actually invading less than 2 centimeter. So finally, what we achieve is that this is a stage 3 papillary tumor. Then it deserves a Whipple procedure, pancreatic head resection, pancreaticoduodenectomy. So you see that for papillary tumors, endosonographic examination is very rewarding. You will stage the tumor and you will make a decision about the management strategy, and you cannot get this view with any other cross-sectional imaging. For papillary examination, the most competitive technique is EUS examination. We are going further back. You see the pancreatic duct invaded by the tumor and the stent. So this is a stage 3 papillovatery carcinoma or a villous adenoma. I am not sure about the pathology, but in any case, even if we perform endoscopic papillectomy, the recurrence rate may be very high. So if the comorbidities are not limiting for this patient, the ideal procedure will be pancreaticoduodenectomy. But if comorbidities are not allowing to do this, then we would consider a deep resection of the tumor. Thank you very much for your attention.
Thank you, Professor Hakan, for the very nice demonstration. And I think we are going to shift to the case number 4.